Um, anyway, for what we're going to do tonight, we're going to talk about mainly two things. We'll talk about whatever you want. If you have a question, please interrupt me. I'm not that organized. You can't mess me up. But what we're mainly going to talk about is how did heart disease become such a problem work? And then we're going to talk about how do you know if you have it. And that's the real problem, by the way, is most people, a lot of people die of a heart attack. They never even knew they were sick. They're just, all of a sudden, they're dead, right? So those are going to be our main topics. That's what I'm going to really try to get to tonight. I didn't even make it, what, 2 minutes?
This
is Mr. Angelmeyer.
Heart attack. It sounds so vicious. Define a heart attack and what it really is.
Okay, what is a heart attack? We can cover that first because it's good to define our terms. And by the way, when I say heart disease tonight, what I mean is a heart attack. What I treat is clogged plumbing, basically. I'm a glorified plumber. I keep blood flowing. Okay, I don't put in pacemakers. I don't treat valve disease. Okay. What a heart attack is when you get. See, ask a question, you start knitting. Are you kidding me? Okay. So you have a clogged artery. Okay, you have a clogged artery, and it blocks blood flow, and that blood would have been supplying a certain area of heart muscle. And that area of heart muscle that doesn't get blood flow now, that dies. If you have one heart cell die, that is a heart attack. Well, you probably have little heart attacks all the time, okay? A big heart attack is when a major artery, like your LAD or some other major artery, gets blocked and your heart has trouble pumping blood. A stroke is when you have a blockage in an artery in your brain and part of the brain dies. They're plumbing problems, okay? So, number one cause of death, the United States. And this is something that, for a while, I actually had a money-back guarantee about. If you had a heart attack or a stroke under my care, I'd give your money back. Okay, this is true. There's 6 other guys in the United States that had a guarantee like that. You can actually do that. It's a little complicated, but it's doable. So, and by the way, I don't have my guarantee right now because my malpractice company found out about it and threw a hissy fit. All right, I don't have a guarantee, but I hope to get it back. My point, though, is it's treatable. So how is it that something is treatable is our number one cause of death? How is that possible? How did that work? I mean, is this the number one cause of death in the world? No. Anybody know what's the number one cause of death on planet Earth for people?
Old age.
Old age. Diarrhea. Diarrhea, by far. No, exactly. You take a skinny little 3-year-old kid in Africa or Central America or Asia or someplace. They got a little bit of dysentery. They carry a little bit of malaria. They're not that healthy to begin with. They're poorly nourished. They get a touch of bacillary. They get diarrhea. The mother gives them water. It's bad water. It's got Giardia in it. Who knows what's in that water? And they get worse and worse, and they die. By far the number one cause of death. So why is heart disease our number one cause of death? Well, because we live long enough. What?
The way we eat?
Well, partially, yes. Well, so yeah, that's about half of it. The other half is we've beaten the other stuff. We're living long enough where we have time to clog plumbing. The year 1900 in the United States, the year 1900, average lifespan in the United States was 46.
That was before McDonald's.
Yeah, there was a lot of things different in 1900. First of all, most people were engaged in agriculture, which meant they worked like dogs. They were burning 10,000 calories a day. And they were busy dying of pneumonia and syphilis and dysentery and whatever else. And now the oldest people in the world have always been around 100 years old. Well, everybody can correct me on a few of those, like Moses and a few others. But in general, everybody else thought, you go to a village any time in history, the oldest guy in that village is going to be about 100. Right? So it's not that our lifespans increase, it's just we have more people making it to about 70 or 80 now. So all of a sudden these chronic diseases like diabetes and cholesterol problems and blood pressure all of a sudden become a problem. If you croak when you're 32, it doesn't matter what you eat, right? You can eat McDonald's all the time if you die young enough. You die of a car crash, who cares what your cholesterol is, right? So, year 1900, our lifespan was 46. Now it's around 80 or so, even a little bit longer than that. So we essentially doubled our lifespan in a century. So what happened in that century? Some brilliant doctors? No. There's 2 big things that happened. It didn't gradually increase by. There's 2 things that happened that increased our lifespan. Number one, indoor plumbing, which meant daily bathing with soap. That made a huge difference. Now, we just got back from Italy. The Romans actually had hot and cold running water, but only very certain Romans. Right? Most of them were living in holes. Right? The other thing that happened was refrigerated transport. So that meant that all of us could eat meat, cheese, and the dairy product, healthier foods. Our food supply improved. So when those two things happened, we started living a long time. And what changed then was our diet became a problem. Something happened in the middle of the century that made this a big deal. President Eisenhower had a heart attack. Pretty young. He was in his early to mid 50s. And that was a big deal. He's very fit, very healthy, very athletic. And this, oh my God, how is that possible? Well, that's when we realized we sort of had a problem. We started looking around, and doctors noticed a few things. This kind of snuck up on us. That was about 1950 or so. Kind of snuck up on us. All of a sudden, my goodness, we are having kind of a lot of heart attacks recently. And they realized you couldn't diagnose it from across the room, like that fat guy with a cigarette in his mouth. No, it's not. It was Eisenhower. He was very healthy. So this evolved over time. When the agricultural revolution happened about 10,000 years ago, we started, all of a sudden, 70% of our calories came from carbs, whereas we hadn't seen a carb in 10,000 years, right? All of a sudden, we eat all these carbs, which doesn't matter when you die young. When you live longer, carbs become a problem, which we're going to talk more about in a minute. We're going to spend a section later on not nutrition stuff. But the point is that now that we've beaten some other diseases, this sort of thing's a problem. So, how does heart disease work? How is it that one day all of a sudden you're not breathing anymore? What happens, right? I mean, that's kind of an important point. And too often in medicine these days, what doctors do is they check your cholesterol. If it's normal, they send you home. If your cholesterol's too high, they make it lower and then send you home. And what are we doing? Now, let me clarify first that our efforts to treat heart disease have really helped things a lot. The last 25 years or so, we've reduced heart attack rates by a lot. And it's possible that if things keep improving like this, cancer may pass heart disease as our #1 cause of death in 3 to 5 years if we keep doing well. But the point is, though, that the point I'm trying to make tonight is we are missing a lot of disease. And that's what we're going to talk about, is the stuff we miss. The stuff you can treat with cholesterol drugs, that's fine, and that's important. That's important. But there's other stuff. So, how is it you wind up dead one day? Well, okay. First of all, this disease takes forever to kill you. It is not a sudden event. You don't just up and die one day. Okay? They did a study during Vietnam. They took American soldiers who died in combat. Average age was 19 years old. So these are perfectly healthy American kids who die of gunshot wounds or something. And they looked in their hearts, and they found that more than half of them had plaques in their coronaries. They were 19 years old. Right? They did a similar study in New Orleans recently. New Orleans is really good for gang warfare, unfortunately. They would autopsy these kids, children, to 8, 10, 12 years old. They found plaques in, I can't remember, I think it was 30-40% of these kids. So, again, it takes forever. So, two things have to happen. You have to build up plaque, and then something has to happen to that plaque to make it rupture. Okay? And that's what we're going to talk about briefly here. So what we're going to do, what I'm going to demonstrate for you is, well, first I'm going to demonstrate why I went to medical school, not to art school. But I'm going to show you an artery and how this works. Okay, so if you have an artery, let's see here, like this. You got blood flowing through the middle of it, and you got fat in your artery, like cholesterol, triglycerides, free fatty acids, chylomicrons, and so on and so forth. That fat soaks into the walls of the arteries, just through simple osmosis. It just kind of soaks in. And you get about the same concentration. And if you have a lot of fat in your artery, then you have a lot of fat in the wall. And what happens is these walls start to get thicker because of all the fat in them. And they start to look kind of like this. Of course, I'm exaggerating. Well, in some cases, I'm not exaggerating. The walls get very, very thick, okay? Now, at this stage, you're not going to have a heart attack. That's really sort of okay. You have good blood flow. It's not the end of the world. What happens then is these macrophages, which are these cells that look kind of like amoeba, they ooze through a pore into this area, and they eat up all this fat, okay? You see, the fat is what fat is, what I'm really talking about is cholesterol here. And cholesterol is a mobile form of fat. That's all it is. There are certain organs in your body that have to have fat to survive. They can't live on glucose or protein or anything else. So you've got to have fat flowing through your body. Well, what happens when you mix fat with water? You cook a chicken, and you get little globules of fat in the water, and it just won't dissolve. Oil and water do not mix, right? Okay. Well, the guy who designed this thing is a whole lot smarter than you and I are, and he figured that out. So what he did was he coated fats with proteins, and the proteins dissolve in the water, and there's fat inside, and that is what cholesterol is. It's a transport mechanism for fat. Okay. So you have this repair mechanism where if you have too much fat in the wall of the artery, as macrophage comes in, eats up a bunch of bad stuff, migrates back out, and it's full of cargo now. Carries it off. Now, what's really cool? One of the things that's so cool about it, this is such a boring disease, but it's so cool. It's so neat. Okay?
You didn't get out much.
Yeah.
I have a fascinating life. I really do. What's really cool about this is when that macrophage eats up all this stuff, it's about 100 times the size it was before. It's enormous all of a sudden. And it can't get back out. It's stuck. It can't get out. So what it does is it breaks itself down into all its component organelles, like endoplasmic reticulum, a mitochondria, and all that stuff you learned about in junior high. And each little piece's part is actively transported through a different type of cell, different type of pore, and reassembled in the artery in a liquid medium, and put together exactly the way it was in here. Now, if you can study subendothelial pathophysiology and not believe in God, there is something wrong with you. That's incredible. I mean, think about that. Can you imagine a person trying to design something like that? This is nuts. Anyway, when that works, it's so, come on. Okay, so when that works, then this stuff is transported off the liver for processing. When it doesn't work, this cell gets stuck in here. So what just happened? All this fat got concentrated in one place. So instead of being distributed, now you have a plaque. You get lots of cells dying in one place. It concentrates the fat you had. Then these bridging vessels that supply the endothelium with oxygen and such, they get the bridging vessels get longer. You get torsional stress. They bleed a little bit. What cell has more fat than the other cell? Red blood cells. It just gets worse and worse. So pretty soon you have an artery that looks like this, and you have a plaque. Now, this is when you're 2 years old. This is when you're 12 years old, and this is when you're maybe 40 or 50 years old. Now, what happens is this does not just gradually grow and grow and grow and kill you. What happens is it ruptures right here at the shoulder one day. All this stuff comes out here, and bam, you have a heart attack. Okay? So it's a sudden event after decades of disease. Now, what do we do? How do we treat this?
Wow, that's good.
See, I'm attracting
It's
even
really
more.
good.
Yeah. So how do we treat this? What we do is we wait for somebody to have their heart attack, and we try to save them. You know, we put stents in, we do bypass, all this heroic stuff, which we are really good at, and we pray to God they live. And then we think about treating the disease, which has been going on for decades. This is nuts. Right? We are ignoring disease. You know, too many people view what I'm talking about here as preventive medicine. Right? Oh, I'm going to put you on this drug to prevent a heart attack, or you should eat healthy food to prevent. You're not preventing anything. You're treating an active disease. Which brings us to, how is it possible that something that takes so long and is so treatable, how is it killing so many people? All right, Mr. Hotshot, why is it? Why haven't we fixed this then? We cured polio, right? Come on. Put a man on the moon. We got a cell phone in my pocket. It's incredible. How have we not figured this out? Well, there are reasons for that. Problem number one. It typically has no symptoms, right? You take men who die of heart attacks, 50% of them have no symptoms before they die. Their first symptom is they wake up dead one morning. That's it. You never even got a chance to treat them. Women who die of heart attacks, 2/3 of them have no symptoms before they die. You don't get a second crack at this. The second problem is you can't see it. You know, it's not like poison ivy or some other Bob Shack. Guy looked healthy. Looked great. Picture of health. Boom, he's dead. So you can't just look at somebody. Doctors think they can. Oh, look at that freak. He's 400 pounds. Yeah, that doesn't, no. Go to a nursing home, look around. You'll see some very heavy people there. If you want to use weight, okay. Let's talk, see how organized I am? Okay, so go to Walmart, close the doors, and try to figure out what everybody's going to die of. You pick out people who are going to die of heart attacks and strokes, you send all of them to Dr. Schubert's office. The ones that are not going to die of heart attacks and strokes, you just take your chances, right? Okay, how do you figure that out? Who's who? How do you know who's going to have a heart attack? What is the best test we have? How do we figure this out? Well, I'll give you a tip. Weight is not a good way to do that. I have some people who are enormous, and they really have pretty good arteries. And I have people who look great, you know, that jogger who dies with a granola bar in his hand, people like that. So one reason this disease is so deadly is because the patient doesn't know they have it, and you can't tell by looking at it. It's asymptomatic. They can't feel it. So what do? Well, we do testing, right? We do labs. We usually do cholesterol, right? Okay, as I mentioned in church the other day, 75% of our fatal heart attacks and strokes, 75% of them have normal cholesterol. So before we even start, you're way behind. Now, if you have high cholesterol, that's important, but what I'm getting at is the predictive value of a test. How good is that test at predicting what's likely to happen in the future? Cholesterol is not very good at that. Women, you know how when you do your cholesterol panel, you get a total cholesterol, a good cholesterol, bad cholesterol, and triglyceride, right? With women, your LDL is supposed to be under 100. Okay. Women, however, their rate of heart attack doesn't go up until their LDL goes over 190. Essentially, it has to double before it actually changes how often they die of heart attacks. Men, that's almost true, but not quite. The point is that cholesterol, for reasons that if you're unlucky, I will explain in a few moments, cholesterol is not a great predictor. So what's the best test we have? So what should we be doing, Mr. Hotshot? So if cholesterol doesn't work, what should we do? What test is that? It's insulin resistance, which trick question. It's not technically a test, I guess, but there's something about insulin resistance that's really bad for you, and we're just now figuring out what all this is. Remember that 3 years ago we were talking about low-fat diets. So I mean, we've come, we're still learning about this as we go. This is a recent disease phenomenon. It takes forever to kill you. You can't do a 2-year study on this. So the science continues to evolve. But what we have figured out is that cholesterol is not that bad for you unless you're resistant to insulin. And in that case, any cholesterol you have is really bad for you. Okay? Now, there is a difference, and okay,
Insulin resistance, diabetes.
this won't be as painless, but it'll be brief.
Insulin resistance, diabetes.
Insulin resistance is what leads to diabetes, right? You become resistant to insulin, your sugar starts to go up eventually. The reason it's important is, there's some tests that are good for risk factor analysis, which means for finding disease. There are other tests that are important for treatment goals, meaning you want to change those tests in order to improve the health of the patient. Like the cholesterol thing. Okay, somebody's cholesterol is high, you make it lower. Are they going to live longer? Okay, well, insulin resistance doesn't really work like that. Suppose your sugar's a little high. I say, aha, it's got heart disease. Okay. I make his sugar lower. Have I made him live longer? No, probably not. Maybe a little. Depending on how high his sugar was, but it's not really good for that. It's great for diagnostics, but it's not a great thing to try to treat. What it means then is when your sugar's high, when you have insulin resistance, that means other things become really important all of a sudden. Now, when you look at your cholesterol panels, and if any of you brought them, I'll look at them later with you if you'd like. The trick is, and the reason they're inaccurate, is that what you're measuring is not really, again, God designed them to carry cholesterol around, and they're particles. And it's how many particles you have that matters. It's not how big they are. So when we measure a cholesterol panel, we'll say, okay, he's got yay much LDL in his plasma. We measure a volume. It's fast, it's easy. He's got yay much LDL. And if he's got the same size particles everybody else does, there's probably about 110 of them in there. And if you look on your cholesterol panels, it'll say LDL calculated or estimated or something. I would say guessed, right? but it's not, nobody counted them. That takes too long, right? That's why I do this fancy test in my office. I send blood work to Cleveland and Texas and Nevada and labs that are particularly good at certain things, because I don't care how big, what matters is how many there are. So if you're insulin resistant and you have small dense LDL, that means if they're small, there's lots and lots of them in there. Like if I tell you that piano is full of balls, how many balls do you think are in there? You'd want to know if there are golf balls or basketballs before you guess, right? Well, we don't check. We just presume everybody has softballs or something, right? So if I told you that piano had 1,000 balls in it, you would think, they must be really small balls, and you'd be exactly right. So the idea is to figure this stuff out and treat what's actually causing the disease. Too often we make their LDL lower, we make the particle size small, and it does. So if you want to know if you got heart disease, the first trick is to figure out, are you resistant to insulin or not? Now, the way diabetes works, 3-minute summary of diabetes. You become resistant to insulin when you're 20, 30, 40 years old. And this is one thing where obesity does matter. People that are overweight do tend to become more resistant to insulin, especially if they have that genetic trait to begin with. They become resistant to insulin. Their pancreas overproduces insulin to compensate for the resistance. They make lots and lots of insulin so they can overcome. And then eventually their pancreas gives up and can't make insulin anymore. And then they're diabetic, right? The point is, your sugar doesn't have to go up to hurt your arteries. You just have to be resistant to insulin. So there's 2 problems with diabetes. Problem number 1, you lose your feet, you go blind, you end up on kidney dialysis, and all those classic diabetes things. But the second problem with diabetes is 80% of diabetics will die of a heart attack or a stroke one day. 80%, unless they're treated. And you know what's weird about the 80% is it's the same 80%, whether you're diabetic or borderline diabetic. It doesn't matter. It's the insulin resistance. So the first thing you want to look at is, are you insulin resistant? Well, how do you know if you're insulin resistant? I'll give you a few tips. If your HDL, the good cholesterol, if that is low, if your triglycerides are high, if your fasting glucose is over 100, now that's really common, by the way. 101 is what I mean by that, okay? If you have an A1C over 5.5, eat something sugary and check your sugar 2 hours later. That's over 140. It's important. Go get a banana split. Use your cousin's meter to check it. It's over 140. That's interesting. And then you get some testing done that will show particle size and particle type. And there's a lot more advanced stuff to look for insulin resistance, what I'm talking about. I go all over the country and teach doctors how to treat this stuff. And the main problem I see is not that they don't have access to these labs, it's they don't know what they mean. I mean, this is kind of complicated. I mean, you think this is boring. I mean, you should hear my doctor lectures, right? I mean, it's a lot of stuff. I mean, it took me, 15 years to figure this stuff out, and now I'm trying to give them 45 minutes worth. It's hard. So you want to find a guy who knows what he's doing with this stuff. So then have him figure out, okay, does he have plaque disease? And if so, why is that? What's wrong? What's causing it? What we typically do right now, again, is we wait for somebody to dang near die, and then we try to rescue them, and then we change a couple labs. You got to remember that if you've got vascular disease, if you're insulin resistant, if you have any of that stuff I just mentioned, then all of a sudden diet becomes really important. I'll be honest, in some people diet doesn't matter. I swear. I had a lady die, this has been a few years ago, she was 98, and she was almost 100, she almost made 100. I asked her how she lived so long, and she said, gin and cigarettes. And she had more than her share of both, believe me. And for all I know, maybe she's right, but her sisters all live to be 100. I mean, you can't kill some people, right? But some people it's really important, okay? Now, so our big thing is put everybody in this diet and hope they live long, but you can pick this out, and what's ideal for you. So how do we avoid this, prevent this from happening? I don't like the word prevent. I don't even use that word anymore, prevent. This is not prevention.
Okay. Guidelines?
Should I do that?
Brief.
All right, let me briefly mention guidelines. So the way we treat this right now is we have what's called guidelines, and this is all over medicine, not just heart disease. We have flow charts. And you're about to get really familiar with these things. They step by step, everybody gets the same drugs, so we do the same tests on everybody, and it streamlines it. Then you have supposed experts sitting around like deciding how everybody should practice medicine, and because this is somewhat complicated, I've just dipped your toe in it. This is a whole lot more complicated than that. So what they do is they say, tell you what, make everybody's LDL under 100. Put everybody in this diet. Make their A1C under 5.5 or whatever. Drives me crazy. Because what they're saying is all you folks are the same. And that is not true. We're all very different. Every heart attack's the same. No, it's not. You need to figure out what's wrong and treat what's wrong. And you don't treat the stupid labs that led you to that diagnosis. You treat the disease. Right? Okay, what's the problem with that? Well, the disease is complicated, right? Just the genetic side. I mean, it's just unbelievable. The biochemistry side is even worse. So we said, well, if not everybody can be an expert in heart disease, so just do this. You can do better. There is better available, okay? So please don't accept just the same as everybody else. Okay? This is important. If you have this disease, this is really, really important, okay? So, is that brief enough?
A little too brief. Oh, he goes to soapbox. He goes on and on. And on.
Guidelines are just. I find guidelines to be immoral.
Well, you're treating the guideline, not the patient.
I think treating everybody the same is just, people are not all the same.
Well, tell them your genetic testing that you do and what you do.
Yeah, okay, just as a brief, okay, genetics is really important. Like, which drug will work for you? Which drug will work for you? Well, it depends on a lot of things. If you don't check genetics, how are you supposed to know that? What type of particles do you expect in your case? What is your actual goal with the LDL? What's your likelihood of disease? How am I supposed to know that without checking genetics? Well, the genetics are complicated, so we don't typically do it. But I'm just saying that I see people come in, I get these referrals, patients come to my office, and stuff's never been checked, and I know what drugs are on before I look at their chart. If you come from the VA, you are on Zocor, you are on hydrochlorothiazide, you're on metformin. Any VA people here? It's always true. Yeah, it's always the same. So I think, okay, somebody's not thinking. General Patton has said, if everybody's thinking the same thing, then somebody's not thinking. The problem with guidelines is we stop thinking. We just follow guidelines, right?
They keep changing them too, don't they?
Oh, of course we keep changing.
300 to 200.
Put a bunch of guys like me in a room and have us bicker over what the guidelines should be. Can you imagine? Yeah. So then what's real, right? What is your cholesterol supposed to be? Well, golly, that depends on a lot of things. And so then I've got a group of experts sitting in a room somewhere telling me how to treat my first patient that afternoon that they've never met. And they don't know anything about it, and they're supposed to write a 2-page summary on what they're trying to do is impossible. So, if you have leukemia, I suggest you find an oncologist who really knows that kind of leukemia. If you have heart disease, find somebody who knows heart disease. I mean, medicine has gotten specialized. It's gotten complicated as our knowledge has grown. It's gotten harder for one person to keep up with all of it.
Use your mom's labs, for example.
Yeah, okay, I'll talk about that. Yeah, Ms. Angel, you had a question?
Where did genetics fit into all of this picture? And the other thing I've heard so much about the Mediterranean diet, but if you're on a Mediterranean diet, you don't live the Mediterranean lifestyle.
That's correct. It's
very
very,
good.
yeah.
So the lifestyle and the genetics, how does it all?
Yeah.
You need to trade your husband in for an Italian. That's
Yeah.
what you do.
The Mediterranean diet's a good example. Like French people. French people don't have a whole lot of heart attacks. They drink like fish, they smoke like chimneys, and they really don't have a lot of heart attacks. So we think, well, we're gonna live like that. I'll just take out of their lifestyle. I'll take the wine, right? And I'll do that part. But I'm not gonna do everything else that they do, right? Also remember that genetic background matters. I mean, all this stuff, like the Pacific Rim. Hawaii, Samoa, Japan, American Indians, that whole area, they're all insulin resistant. Asian Indians, if your name is Patel, you are insulin resistant. It's always true. I gave a speech to a group of Indian doctors in Florida once, and they all knew that. And they're not insulin resistant like Americans. They're just. So genetics matter a lot. And if you don't know who you're looking at, like I'll get copies of labs. A doctor will send me a copy of labs. Hey, can you look at this for me? And say, how am I supposed to look at it if I don't know who? Just some guy. It's a piece of paper. You got to know the person you're talking to. Part of that is genetic background, but there's a lot of other stuff to it as well. We're all different. You can't treat this the same. It doesn't work. If we ever have one drug that does work, we'll just have one drug, right? Yes.
I want to know. I have AFib, and I also had 3 TIAs. Are TIAs small strokes?
TIAs are temporary strokes.
It's a temporary.
So you have a stroke, but the symptoms
Can it
resolve
happen
within.
again?
Oh yes, it's a warning sign. So if you have a TIA, you have a stroke, and it resolves in 24 hours. That's what a TIA is. There's no permanent damage. It means you've got a bad spot somewhere.
There's still numbness here.
Well, that's not TIA then. If you have any permanent symptoms, that was a stroke, which means you may have another stroke. Which, by the way, is one of my I have a lot of little pet peeves, I guess. I should try to get over some of this. But
AFib related to it at all?
Oh yeah, AFib causes strokes. Yeah.
I got that too.
Yeah. So one of my many pet peeves is I think it's 50% of our heart attacks every year are in people who've already had a heart attack. So at that point, we're not guessing fancy tests or hotshot lipid geek to tell you have heart. We know you have heart disease, and they still have another heart attack. That shouldn't happen in my view. Strokes are a little harder. If you have AFib, you may have a stroke. Now, there's ways we can reduce your odds by a lot.
Like what?
I don't know. 80, 90%. But we can improve your odds by a lot. But we can't make your odds zero.
I exercise all my life, hard, exercise.
Good. Well,
And
let's...
I don't eat really bad. I
Yeah.
eat really bad.
Yeah, let's talk about eating bad for a moment.
I don't like ice cream, I don't like french fries, I don't like, a lot of this stuff I don't like.
Actually, have you ever had french fries with ice cream on them? The Dairy Queen with...
Oh,
No,
disgusting.
it's actually
Oh,
pretty
come
good.
on.
It is.
Yeah.
Plus,
That's
it's
nasty.
actionware.
Yeah. Let's talk about food. All right? Because what we put into us is contributing a lot to this. Now, as I said, there's a lot of other stuff. And Miss Jenna's cigarettes apparently didn't matter, but in some of us it matters a lot. So what we used to say, okay, so in Eisenhower's time, we started trying to figure out what was causing his heart disease. We'd take dead people, look in their hearts, we'd find this white greasy stuff in the walls of their arteries. So he had too much fat in their arteries, too much fat in his belly, he should eat less fat. Which makes sense. I mean, you can understand how we got fooled by that. For 50, 60 years, we told people to eat less fat. Well, as it turns out, that was wrong. It made a lot of sense, but we were wrong. Again, we've been digesting fat for a long time. Used to be humans ate whatever animals we could catch, fish, birds, insects, nuts, vegetables we found on the ground, fruit when it was in season, and that's everything we ate, right? So we've been digesting fat for a very long time. One other point of that, by the way, is we used to eat only occasionally. Remember, we were designed to chase buffalo around or mastodons or whatever, and we'd eat once a month whenever we caught a mastodon, and we wouldn't eat much in between. Eating 3 meals a day is probably not ideal for humans. Now, I intend to eat my 3 meals a day, and that's the point. We got to do it the best we can here, okay? We're living in East Tennessee. This is not going to be perfect, all right? I was doing a little presentation group of Baptists at one of their churches, and I made a crack about Baptists, and he said he didn't see a lot of Methodists starving to death either. And I said, okay, that's fair. That's fair. But the point is, our culture is what it is, you know, and I intend to eat. There's a guy named Esselstein in Cleveland who came up with this diet to prevent heart disease, and it worked perfectly. He's had 0 heart attacks in like 30 years. He started 10,000 people on this diet. This is in 1960 something, believe it or not, and basically greens with no oils, and that's it. Kale, lettuce, you know, raw vegetables. Now, started 10,000 people on this diet. Now he's got like 11 of them left. Because they all dropped out. You know, they didn't die. I mean, they're alive. But so, and I listened to a 1-hour lecture by this guy. And I'm thinking, how does this help me? I'm going to go back home to Tennessee. I'm going to tell him, no, this is not going to work. I will not do that. Right? So we're talking about doing the best we can. All right. We're not. Some of the things, some of the stuff Margaret made, that's not a technically health food, but it's a whole lot better for you than you could do. Right? We're trying to improve on this stuff. So, basic concept is that we do not process grains very well. Okay? We're going to do about 5 or 10 minutes on diet. And incidentally, if any of you have an interest in this, and you think I was too brief, if you talk to Reverend Wright, I will spend as much time. We'll do this once a week, once a month. I'll do it one more time. If there's a topic you want to hear about, tell him, and I'll do it again. Okay? On a certain topic. I feel like 10 topics in the real brief. Okay? Just trying to get through it all. Anyway, diet, grains. Humans don't digest grains very well. We're not cattle. We don't have 4 stomachs. We've only been eating this stuff for a few thousand years. We just don't do it very well. So you eat fat, you break it down, and by the time it gets in your bloodstream, it's not more. It's been turned into other forms of nutrition. You actually digest fat fairly well. Carbs, however, especially carbs from grains, are pure energy. And your body doesn't know what to do with them. It dumps it into fat. You store energy. Remember, humans have lived in a state of starvation for most of our existence. Not here, by the way, but for most of our history, we've lived very close to starvation. We had to store energy. Look at the Samoans, those people riding canoes across the Pacific. If you were a little chunky, you did not survive that canoe ride, and look at them now. They're all chunky, right? half the NFL linemen are Samoans, and there's a reason for that. So we want to store energy, and carbs are a great way to store energy. Well, right now, we're not trying to store energy. But grain-based foods dump fats into, I shouldn't have erased that, dump fats into your bloodstream. So what does that mean? So grains mean cereals. You know how we told you to eat oatmeal because it's good for your heart? Anyway, hot cereal, cold cereal, any kind of cereal. You know, oatmeal is oats, cream of wheat is wheat, any Wheaties, Cheerios, they're all grains.
Rice.
Cereals, breads. I don't care if it's whole wheat bread, it's wheat, right? It's bread. Okay? Cereals, breads, pastas, and rice. That's grain. Now, I had a few of my patients. We did the Second Harvest Food Bank thing the other day. We're handing out food. By the way, which I want to take away about half of it. I just couldn't quite. I said, no, you can't. Anyway, when Margaret worked in Africa for a while in the Peace Corps, and she would tell the people in her village there, the village people, she would tell them, you know, where I come from, our poor people are fat. And they didn't believe it. So, well, if they're fat, then how are they poor? They're stupid American. What do you know? You hand food out there. Look around. That's the real problem we have in our hungry population. We're helping our hungry. That's the main problem our hungry have, is they're overweight. Right? Why is that? Well, it's because carbs are cheap. Right? You can, a pack of ramen noodles is what, 19 cents, I think? A bag of rice is a few bucks. You know, I was in medical school. I lived on rice and bread. I mean, it was free. Beans, it's free. So eating healthy actually costs a little bit of money, short term. Now, guys like me are not cheap. So long term, I think it works out, right? But and how much money have you spent? I mean, you know, heart attacks are expensive. Stroke is the most expensive thing our government spends money on. Medicare spends more money on stroke than it does on anything else. Because, I mean, you got the surgery, bypasses, then you got the rehab and nursing home. Nursing home's what, 30 grand a month? It adds up fast. So, yeah, it costs a little money, but this is cheap long run, right? But that's the problem. Our poor population, they're eating a lot of carbs. And look what we're doing.
Okay, so what are you saying in overall to prevent a heart attack, eat better, exercise, and go see you?
Yeah.
Okay.
Well,
Just
go see me and see if you're going to have a heart attack. If you're not, then you may not need me, right? Which would be swell. The dietary thing, I would suggest just avoiding grains, and beyond that, for a lot of us, that's adequate. Some of my patients, I tell, if you just don't eat grain, I don't really care what else you eat. That's an overstatement. Oh, I didn't think I'd get away with that. Yes, Ms. Ameline. I thought she was going to stop me on that one.
Quinoa. What do you think of quinoa?
Quinoa. It's a protein. It is a protein, but it's a grain.
Well, that's why if I have a patient with a scale in their kitchen, it makes me nervous because of things like that. What about quinoa? It's a type of protein.
Quinoa.
It's a type of protein. I'm trying to be general here. The basic point is grain is bad for you. For you, not for your
Quinoa.
goat or cow. But for you, grains are difficult. On that, yes, there's a lot of detail. And in some people, with certain genetics, certain types of disease, whatever, that's where I earn my money, is figuring out who needs what. But in general, grains are bad. Okay? We got 5 minutes. Grains are bad. All right?
Fits into the grain category.
Yeah.
Yeah, it does.
Yeah.
I'm sorry. Yeah. Point number 2, exercise. Exercise is important because it helps keep your artery healthy. If you do have a heart attack, you're more likely to survive it if you're fit. Exercise it's very difficult to lose weight with exercise. And I see this a lot. People that they get to 200 pounds or 300 pounds, whatever, that line, we all have a line somewhere, and they say, that's it, I'm buying a stair machine or something. That's a hard way to lose weight. I mean, if you eat a Snickers bar, you've got to jog for 45 to 50 minutes to burn off that Snickers bar. So it's easier just not eat the Snickers bar, right? Diet is how you lose weight, by changing what you eat. Not even the calories matter. They do. It's basically calories in, calories out. But the type of calories matter a lot. When you eat carbs, when you eat grains, you release all sorts of bad stuff, which I could bore you to tears for hours, but bad stuff when you eat grains. those calories are really bad for you. So if you want to lose weight, you use diet. If you want to stay fit and help your heart, you exercise. And then part of this is drugs too. I'm sorry to say that, but certain people, medications work great. And that gets a little complicated because we're all different with that, so I'll just leave that where it is. But I just said, I don't care what you say. I am not taking any pills. For some people, that's really difficult. Unless they go to Dr. Esselstyn and basically stop eating, right? And by the way, the diet does work to a certain degree. Like in England, early 1940s, type 2 diabetes ceased to exist. Disappeared. We sent them medicines to help them out during the war, and they said, you can cool it with the diabetes drugs. We don't have diabetes anymore. Why is that? They were starving. It was during the Blitz. They're sending all their food to the military. They were starving. They didn't have diabetes. Diabetes is no longer a problem. You could fix all this with diet if you're brutal enough. You put me in charge, I could cure diabetes tomorrow if you asked me to, but it's a bad idea, okay, because you've eaten stuff I would eat, right? So eating stuff that we want to eat makes things more complicated. Sometimes you have to use medicines. But avoid grains, stay fit, see somebody who knows what they're talking about to see if you have heart disease or not, and if you do, for God's sake, treat it. Don't wait for your event. By the time you start having strokes, heart attacks, things get complicated. Please treat this upstream. Why are we waiting? We have 60-year-olds having heart attacks that have had this disease for 40 years, and we've ignored them. Yes?
Do supplements help?
Supplements. Like protein supplements, things like that?
No, like vitamin C or
Yeah.
what I spoke to you the other day, D3
Yeah.
and all that stuff.
Yeah, for some of you folks, he's asked if vitamins and such help. And you've probably read some of the stuff where vitamins cause cancer now. Yeah, it came out in the major media. I've gotten lots of questions about it recently. And that's probably true. But remember, though, we've been on this vitamin kick really since the late 70s. And some people have been taking lots of vitamins. You get those pills, the great big brown ones that smell really bad, and they got like 1,000% of your daily requirement of some vitamin you've never heard of. And so, as it turns out, some of that's probably bad for you. Too much of anything is bad for you. Too much water is bad for you. You drown, right? I mean, it's an overdose. So, as it turns out, some of these supplements are not a great idea because the doses are so high. Now, certain vitamins are good for heart disease. Vitamin B3 is great for heart disease. There's a few others. And B3, by the way, just contradicts everything I said, because the more you take of that, the better. But
Okay.
it makes me nervous when somebody comes in and they here are my medicines and here are my supplements.
Right.
That's generally not a good thing.
Okay.
We didn't live the last million years taking 10,000 milligrams of thiamine a day or something. You know what I mean?
Mm-hmm.
So 100% of daily requirements. But remember that in America, our diet is so rich. I rarely see vitamin deficiencies. Now, when I went to medical school in Toledo, Ohio, and we had, Detroit, Toledo, and we had a large Muslim population where the women had to wear the burqas, yeah. And I saw some vitamin deficiencies there because they didn't get a lot of sunshine and their diet was unusual. But for those of us in this room, you're not going to see a lot of vitamin deficiencies. Yes?
So somebody has gone somewhere and gotten a lipid panel. What on there should alarm them so they think, maybe I
Okay,
should
so how do you
take
read a
it?
lipid panel?
Yeah.
Well, first of all, let me say that I'm not sure. They're really hard to read. Because if you don't know what size the particles are, how are you supposed to know what that means? Secondly, and it sounds weird for lipidologists to say this, I think we should ban lipid panels because people don't know how to read them. I guess including me. I mean, what do you do with it? 75% of our heart attacks are people with normal lipids? Jeez, I don't see how that's a helpful test. I mean, if we were finding breast cancer with a test like that, we would dump it. We'd find something better. And we have something better, it's just kind of complicated. Having said all that, HDL is important. Women, if your HDL is under about 50. Men, if your HDL is under 40, it's not so great. Now, there's other things that have to be present for that, but low HDL, the good cholesterol where you want to have it, that is important. LDL, the bad cholesterol, it's not that important until it gets really high. Unless you have vascular disease, in which case any LDL is bad. But in that case, it's wrong. What's on that form? Your LDL. If you have heart disease and it says your LDL is 130, that's wrong. I don't know what it is, but I can tell you it's wrong. Find somebody who knows what we're talking about. Triglycerides are a controversial area. Your triglycerides got to be pretty high before they hurt your heart. They're supposed to be under 150. Incidentally, if you check triglycerides around the world, the average triglyceride on planet Earth is about 50. In America, we say 150 because our diet is so rich. We run high on triglycerides.
What caused it? I mean, what is dietary?
Triglycerides?
Yes.
Yes, diet.
Diet?
That's diet. Now, some
Grain,
lipid part.
too much grain?
Yes, exactly. You don't cholesterol carry little bunches of triglycerides around. Triglycerides are like the cargo, and cholesterol is the truck. All right, so you got a truck full of triglycerides carrying around, and those triglycerides are the original fat particle. And when you eat bread or something, you dump it into triglycerides. Rice, yeah, especially Pacific Rim, Japanese, Filipino, whatever.
Yeah. Oriental has a lot of diabetes.
Yes.
So I would.
And it's not just the rice. I mean,
Not the rice.
I've got a Japanese lady in my practice, married a GI, came over here, she's 60-something. She doesn't like rice. A Japanese lady, I make all these jokes about. She doesn't like rice. She's a horrible diabetic. Horrible. It's not the rice, it's the genetics.
Oh, genetics.
But my triglycerides are low, 40.
As I say, it's not a good predictor. It helps, but it's not a good,
Yet I have a problem.
Yeah, remember we got AFib though. It's not that simple. That's why I don't like guidelines. It's not that simple.
What role does inflammation play in heart disease?
Sorry?
The role of inflammation in heart disease.
Oh, very good, very good. What is the role of inflammation in heart disease? 2-3 minutes I can do this. First of all, it's important. When that plaque ruptures, that I so brilliantly erased, when that plaque ruptures, that is probably an inflammatory process. Your arteries, the lining of that artery that's covering the plaque, when that becomes inflamed, it becomes less stable, and then the plaque can be released more easily. So if we can treat the stability, and I actually describe myself as an endotheliologist, even though I don't think there is such a thing, but because I think I'm treating the lining of that artery. And that's an inflammatory process. The problem with all this, however, is suppose I punch you in the arm and you get a bruise, and it hurts, and it gets red and swollen and warm, and then it turns purple, and it's all big, and then it turns yellow and green, and in a few weeks you have what looks like a normal arm. Okay, is that an inflammatory process? Of course it is. It's red, it's swollen, yeah. Now, I would call it healing, okay, but that is certainly inflammation. The problem is when we find these inflammatory markers in the walls of arteries, is the artery diseased or is it trying to heal itself? Should we be intervening there? We keep forgetting this, but the guy who designed those arteries is a lot smarter than we are. What is the role of that inflammation? What is it doing? Just as an example, suppose you have angina, where you have chest pain from your heart, and you go to the ER. Okay, well, if that's an inflammatory process, we should put you on prednisone, on steroids. It's the ultimate anti-inflammatory. The best inflammatory drug we have. Why don't we do that? Because prednisone causes heart attacks. Well, what the heck is that? Right? Aspirin is also an anti-inflammatory. That does prevent heart attacks. Naproxen is an anti-inflammatory. It causes heart attacks. Which is it? We don't know. We don't understand. So yes, it plays a role. And I do check a lot of inflammatory markers because I can smell heart attacks coming that way. But what is the role? How do they work? We're just not sure yet. Now, I think that we're going to, we're pretty good at, okay, so we have drugs that work for heart disease. I don't mean to keep pointing at you, I'm talking to you now. We have drugs that work for heart disease, and again, if I can find it, I can treat it, okay? The problem is diagnosis, you can't feel it. So when we treat a lot of people with drugs that don't have heart disease. So it becomes, so really the trick to this disease is not the treatment, it's the diagnosis and making sure your drugs are working, that's the trick. So if you have an inflammatory process, I don't know how to say this, but we spend too much time treating markers and not the actual disease is what I would say. That part is complicated. But it's real, it's real. I think someday we'll have treatments like Humira for rheumatoid arthritis. Stay tuned, I think that's going to treat heart disease in about 5 or 10 years.
Could you explain the role of the stent, and can a stent get blocked?
Okay, a stent is a little pipe you put in a coronary, so you have a coronary artery that's been squeezed shut by plaque. You put a little slinky type of pipe in there, we let it release itself and it pushes out the artery, and then you got a nice pipe to have blood flow. Yes, they can get blocked, common problem. One of my jobs, I had a patient once with 21 stents in their heart. Vanderbilt. I called Vanderbilt. I said, "Can you put 21 stents in a heart?" They said, "Yeah, you actually can." Because I thought this lady said, "I said, do you have stents?" "Yeah." "How many?" 21. Oh, this lady has no idea what she's talking about. Right? No, she was right. She had 21 stents. So the advantage of stents is we get immediate relief to angina, and we get blood flow like that without having to crack their chest. Disadvantage: we have yet to show that people live longer with stents. They're good for symptom treatment, but do they live longer? We're not sure. Real briefly, blood flow is not like water running down a mountain in a stream. Blood just doesn't go wherever it gets pushed. It chooses where to go. Your cells in your blood know where they're going. We've done studies on warts where, anybody heard of scaring a wart? You heard of this? It actually works. Suppose you come to me with a wart, and you say, "Hey, doctor, take this wart off." And I'm in a bad mood, I don't feel like doing it that day, I want to blow you off. So I say, tell you, I can take it off, but it's a very difficult, very painful procedure. It takes a long time. I just don't have time. It could come back in a month. You come back in a month, and the wart is gone. It's called scaring a wart. I was actually taught this in medical school. It actually works. Now think about that. What does that mean then? That means if your body really wants to, it can send white cells to that very spot. So we've done studies using radionuclide tags on certain types of white blood cells. We scare the wart, we scare the heck out of the person. We do scans, and we can see the white blood cells for that type of wart going to that spot. They know where they're going. Those cells get to a intersection in the artery, and they choose which way to go, and they're right. If you can study this stuff and not believe in God, there's something wrong with you. Anyway, if we ever figure out how that works, then we just cured cancer, right? You have pancreatic cancer, I can give you chemotherapy tagged just to your pancreas and have no side effects. It all goes right there. Think of what we could do with that. The point is that sounded like a tangent. It actually wasn't. Aren't you proud of me? The point with stents is we cover all that up. And the blood's just flowing through like water. And whatever that lining does to tell the cells where to go, that doesn't work anymore. So yeah, we get blood flow, but it's not the same. It's not as good. We're not sure if it helps heart disease long term. Now, what's the alternative? The alternative is do a bypass on somebody every time they have chest pain. It's not a good alternative. As I was saying with diet, we often do the best we can here. Stents are great. We can get a stent anywhere in your body except some parts of your brain and your eyeball. And we can put a stent anywhere else. The stent jockeys are brilliant now. They're great. I'm just saying they're not quite as good as you may think. And in my view, once you have a stent and somebody, mainly me, has screwed up, that shouldn't have happened. Now, that's pretty harsh criticism because, we can't find this disease half the time, so it's going to happen, And if you've got it, a stent's a great way to go. But yeah, they get clogged a lot. It's a problem. Bypasses get clogged a lot. It happens.
So if they get clogged, then you're back to the heart attack.
Right. Same thing. Yeah, you can put a stent in a stent. We actually do that a lot. When you have a stent in a stent, it means somebody needs to get busy. You've got disease building up. You treat it, and it builds up again. Something's not working right. You got to fix that because it will keep happening. And every time you put a stent in, you should feel lucky. Oh man, okay, I had an 82% blockage. I fixed. Oh wow, what a beautiful day it is today. It's a good day after a stent. That works out, but you can't trust that. Treat it, and you treat it with drugs because then if you have blockages here, you probably have blockages elsewhere, right? You just treat them all. You don't know where the other ones are.
That's the role of the blood.
Blood thinners play an important role. It's part of it, yeah. Other questions? Let me get these people and I'll come back to you if we have time. Yes?
Speaking of inflammation, especially regarding your heart, isn't the C-reactive protein test a good marker for inflammation?
Good question. C-reactive protein was developed by a friend of mine, Paul Ritker, in Cleveland. He's a brilliant guy, although don't tell him I said that. And he came up with this inflammatory marker. He was trying to measure inflammation in the arteries. And what they did was they were using C-reactive protein to diagnose heart disease instead of cholesterol or whatever. That didn't work out so well. They did a study called the Jupiter trial where they used C-reactive protein to pick people out. So if you had a high CRP, they put half those people on Crestor, half of them on placebo. the number of people in the high CRP group that had a heart attack, it was 2.7%, meaning 97% of them did not. So 2.7% is something. It's not nothing. But if you're trusting that to diagnose heart disease, I would argue it's flawed. Now, I do them, and it's an important part of all this, but it's part. It's a small part. But it's valid. Other questions? I saw some other hands. Yes?
Getting back to the grains, is this why there's so much about gluten-free?
Good question. Gluten-free diets. So yeah, I have people come in. One thing about a low-grain diet is you feel better because when you eat grain, you release insulin. The insulin makes you tired. You know how when you eat Thanksgiving dinner and an hour and a half later you feel like you need a nap? That's insulin. If I injected you with insulin right now, you'd be asleep. Well, you may already be asleep. But you would be asleep in about an hour, right? The insulin makes you tired, right? So people go on this low-grain diet. Oh, man, doc, I feel great. That's awesome. So people go on this gluten-free diet, and they say, oh, wow, I feel better on this gluten-free diet. It's definitely better. It's not the gluten. It's the grain. It's not the gluten. Because if you go on a low-gluten diet, there's not much grain, because that's where the glutens come from, right? You skip the grain.
Yeah, that's what I'm saying.
And I'll have people say, oh, doc, I swear it's a gluten. I'll say, great. Stay off the gluten. But it's the same. That's how it works out. It's not, but gluten has all it's supposed to be inflammatory, cause allergies, arthritis, all this stuff. Grains are just not good for you. I'm not convinced it's a gluten. We haven't been able to separate that out in labs.
Well, I think our nutritionists need to be on board with this because they talk a lot about eating the food groups and
yeah, I know.
grains are one of them.
That's fair. We have a lot of, I have, this is going to sound really arrogant and condescending, which is a problem.
We'll get over
I have chiropractors giving dietary advice, telling people not to take vaccines, or physical therapists or whatever. There's a lot of diet. I tell you, anybody's a nutritionist or dietary, which I rely on heavily. I have dietitians come into my office. If you're in my practice, we have counseling, we have classes, we have all this stuff with dietitians. I love dietitians. But anybody who does dietary stuff for a living is odd.
Hey, wait a second.
I'm sorry, it's true. They get off on these, I mean, wild diets. You know, when you see a dietitian's like 20 pounds underweight, they're just, okay, that's a different kind of person, you know. And I need their expertise, but I'm just saying they're just a little different, you know. Go to a dietary conference. They have conferences, ETSU once in a while. Go to one and check it out. I mean, this is a different. It's a religion. I don't even like talking about diet because, Friedrich Nietzsche said it's easier to change a man's religion than his diet. And I think that's true. I mean, you know, I'll be doing one of these lectures. I'll do a dietary lecture somewhere, and I'm doing really well until I get to the sweet tea part.
Yep.
And they're gone. I'd lost them all, you know? People get angry, you know? It's comfort foods. It's a cultural thing. That's why my mama made it, on and on and on and on and on. So if you do this for a living, you are a little bit of it. You're a passionate crusader in the face of evil. It looks bad, you know. People get serious about this stuff.
Let me interject here. Sorry. Well, his point is that right now, sorry, but the nutrition world is really turned upside down. Because when he referring back to the low fat, when we were on the low fat diet, I mean, I'm still trying to break my habits from that. And you know, the health pyramid, it was, you know, all the carbs and all. Now that's upside down. And my point is that we don't really know, and that there's a wide school of thought on nutrition right now. If you go on all these websites and all these different, everybody has a different opinion.
Mine is correct.
Of course, his of course is right. Yeah, we're sort of embracing the paleo idea, and that, you know, low grains, low carb, and if you try it just for even 3 days, you will feel better. And the gluten free is beyond gluten free, just because gluten free means, you know, rice flour, substitutes for flour. No, this means cut out the grains altogether. Now, like what I made today was I use almond flour, which is crushed up almonds, which is a nut, high in fat, a lot of antioxidants and vitamin E and all that good stuff. So, yeah, you kind of got to pick a route and go with that and see how you feel with it. And we think that the paleo way of no carbs, because of what happens to your body when you eat a carb and the diabetes and heart disease that follows, that's sort of our position.
And let me add one final point, and I'll stop. The low-fat diet that we had people on for 70 years or whatever it was, from Eisenhower till about 3 years ago, that is one of the great mistakes in the history of medicine. We killed millions with that diet. And it didn't happen all of a sudden. World War I, we were sending all our meat overseas, and we tried to convince farming women that Crisco was good for you. It's not that you're being forced to eat this, which you are, because we're sending our lard overseas, but Crisco is actually healthy because it's vegetables. See, it's vegetables, it's not pigs, right? And then the Eisenhower thing, we saw the fat. We didn't really understand how fats worked. We just knew there was too much of it, so he told me less fat. So you can see how this happened. We just kind of got taken. And in retrospect, you look at the numbers and think, oh my God, because when we told people to cut fat out of their diet, what did they replace it with? Carbs,
Sugar.
right? And high fructose corn syrup. Oh my God. And speaking of rants, if we don't get the first primary out of Iowa, we're all going to die. Okay? Because we subsidize corn, it makes corn really cheap. What do we do with all this freaking corn? Well, we make high fructose corn syrup out of it. We put it in our gas tanks, damage our cars, but it's in us, it damages us. High fructose corn syrup is poison, all right? But we keep making it. We have made mistakes in the dietary world. We are killing people. The low-fat diet was a big mistake. Now, it's easier for me to sit here and criticize. We just didn't know. I mean, we were doing the best we could at the time. But in retrospect, that was a real doozy. Okay? So, let me just wrap this up by saying, and I will stay here as long as you want and take individual questions, by saying that I view heart attacks as a waste of life. This really shouldn't be happening. There's always going to be a few here and there, I suppose. But it's kind of like colon cancer. Justin Digby in our church is a brilliant surgeon. He probably views a death from colon cancer as it probably aggravates him a little bit. Whenever I have somebody die of colon cancer, it just makes me mad because I know we probably could have fixed it and found it earlier. Heart disease is even more so. It just drives me crazy to see the numbers. This is treatable. In order to treat it, you got to find it, and that's the hard part. Please get checked out by somebody who knows what they're doing more than looking at a lipid panel. And by the way, another point, I'm not criticizing it. I think I've made that clear, but this is complicated. I have to be good at this. I'm completely incompetent in other areas of medicine. Okay, there's other things I don't know anything about. This is what I'm good at. Okay, find somebody who knows what they're talking about. Find out if you have this disease and do. Please treat it before something bad happens. It's really hard to treat after something bad happens, especially if you're dead. Okay, I'll just do one more question. Then I will stay right here and I'll take all the one. Yes.
Mine's actually a two-part question.
I'll get you in a second.
When you were talking about the high fructose corn syrup.
Yes.
Reading the labels on your foods that are the foods that you buy that are bottled and jarred, there's they really trick you now because when they list high fructose corn syrup, they'll list corn syrup again.
Yeah.
Which basically means that there's a lot more high fructose corn syrup in that product than they're really leading you on to.
Well, and the point is, if you want something sweet, make something sweet and use sugar. Sugar cane, sugar, not
the real thing.
Yeah.
The real thing. And stay away from the pink stuff, the blue stuff.
Whoa, no, I disagree with that. I disagree.
But anyway, okay, but my other question was, if someone's triglycerides were extremely high at one point.
Like 3,000 or something?
Over 1,000.
Okay, fine.
And through a number of years, they've gotten it down now to a good level. Has the damage been done?
That's a good question. Suppose I have somebody come in at 300 pounds, I put them on all these drugs, and then they get down to 200 pounds. Should I stop everything? I don't know. That's really hard, and it would depend on a lot of things. I can't answer that without seeing the situation. All right, let me close. Thank you all for coming. Thank you so much for coming. If you are interested, talk to Reverend Ray. I'll do as much of this as you gluttons for punishment want. Please let me help, though. This shouldn't be happening, all right? Thank you so much for your time. Good night. Yes.
We're high?
I hope you get the help you need.
Thank you, I appreciate that.
A good person. I think
He's the only person we're that knows this stuff.
I was checking with him to see if he knew Del Dickey because he went to